So besides schizophrenia, I already mentioned that they can be used for mood stabilizing properties in bipolar mania and or depression, depending on the exact drug. For Tourette syndrome, aripiprazole is also indicated along with haloperidol. Same concept about behavioral problems, just prioritize non-pharmacologic intervention. And as I mentioned earlier, in excitement, they can also be used as adjuncts to mood disorders like unipolar major depressive disorder for the next module, and generalized anxiety disorder, particularly quetiapine, and obsessive compulsive disorder, aripiprazole and risperidone. And for the mechanism, we talked about all of the mechanisms na. But in addition, take note that you see that circle there, that's a figure from Stalls by Nancy Munter. They also have multiple receptor affinities at muscarinic receptors. The ham blockade is still there, and there are some other alpha receptors also bound, other dopamine receptors. There's a lot going on, even the serotonin receptors. So onset of action for mood, usually give it a week, and there will be some improvement in mood. For the positive symptoms, similar brain to first generation because the main receptor being looked at is still D2. And for full response, 4 to 6 weeks. Administration with or without food, and nothing fancy naman. Oral, take note that we do have long-acting injectable depot injections again, this time for olanzapine, aripiprazole, risperidone, paliperidone. In the Philippines, we only have risperidone and paliperidone and aripiprazole. Olanzapine, we don't have that. Na long-acting injectable. Okay, contraindications, similar still. Parkinson's, even for partial D2 agonists like aripiprazole, are contraindicated in Parkinson's, but it seems that there may be some exception for clozapine. Quetiapine medyo iffy, but for clozapine, it's possible. So if you haven't read it yet during the ENS module, I recommend you check out the Beers criteria for potentially inappropriate drug use in older patients, because a bunch of anticholinergics are on that list for valid reason. But it seems they put a note there looking at the evidence for clozapine and quetiapine in Parkinson's disease psychosis. So just think back to the meter diagram there. The rebound symptoms again, rebound cholinergic, rebound insomnia, rebound psychosis can still occur if you discontinue immediately. And don't forget, we want to emphasize still the recovery-based approach. We don't want to just get rid of the symptoms. We want them to regain a good quality of life, whatever it may be, depending on their priorities in life. Black box warning, do I have to repeat this? It's the same thing as earlier. Same, same, same. Okay, side effects, we're going to deviate a bit here because a lot will say na, oh, we like second generation antipsychotics more because they have less EPS. Again, there are exceptions there. They have less hyperprolactinemia. Again, they have exceptions there. But is there a trade-off? Yes, there is a trade-off. If you look at the diagram there already, you can see what the trade-off might be. The side effects, they're pretty generic. They can be predicted based on the receptor binding profile, so binding to serotonin receptors in the GIT, no, and in the chemoreceptor trigger zone, 5-HT3, right? Nausea, vomiting, diarrhea, the CNS side effects, they're given, orthostatic hypotension, alpha-1 antagonism. What about that aspiration pneumonia? Where did that come from? Because it seems that if an antipsychotic is very sedating, particular talk about the antipsychotics with the letter Z in them, they tend to be more sedating, except for aripiprazole. And what happens when you're sleepy, you're unable to swallow properly. And if you're unable to swallow properly, your saliva may end up aspirated into your lungs. And what does your saliva have? The normal flora in your mouth, aspiration pneumonia. So that's something you have to watch out for. Now, what's the big trade-off for the decreased incidence in EPS and hyperprolactinemia? I just want to correct our misconception here that EPS and hyperprolactinemia, they're impossible with second gen, third gen. No, it's still possible. But the biggest trade-off, I would say, would be the metabolic side effects. So, yes, first generation antipsychotics can cause weight gain, but usually there is no changes in blood sugar and lipid profile. But it seems second generation antipsychotics, a lot of them, almost all, we only have some exceptions, almost all will cause problems. If you look at the table there, I put in there the table. If you want a quantitative comparison of how bad are the changes exactly with these antipsychotics, then we check out that table there. That's one thing that mental health service users aren't routinely told about. And so it's our job to warn them about this and to have them monitor properly. We'll talk about the monitoring part in a bit. But you have to tell them about this. So, true or false? Second generation antipsychotics are automatically superior to first generation. Obviously, false. There are some textbooks that promote this misconception. If that were the case in communities, we would no longer see haloperidol, fluphenazine in much use, but it still is. So we still do have use for these agents. Usually, the basis for comparison will be, in the Philippines, it will be side effect and cost. So besides cost, some people will actually prefer not to have diabetes, will not prefer to have dyslipidemia. They would actually be okay with EPS. So again, there's also a patient choice in that matter there. QT prolongation. So if you remember the halo-halo, mnemonic, quetiapine first, keso, halo-halo, mapride. So quetiapine and amisulpride can significantly prolong QT interval. Risperidone, it might be possible, but it's not really sure. I think the color made it clear. Red is bad with the values in the table. So later we'll talk about which of those drugs have it worse for their metabolic profile. We'll go to them individually, actually. Rare. Okay. So if you look at the right side, we have another forest plot. And this is just to demonstrate it's not just first generation antipsychotics that cause hyperprolactinemia and EPS. In fact, we still see this for again your risperidone, paliperidone, and apparently, I forgot to note this exception, so please write this down. Amisulpride. Amisulpride can cause an increase in prolactin as well, so same side effects. But for EPS, it's only risperidone and paliperidone. Now, again, true or false, second generation or quote unquote atypical antipsychotics cannot cause EPS. False. They still can, just at a lower risk. There is one exception. We have a lot of exceptions here. There is one exception in this manner that will be clozapine. I think I mentioned this earlier already. That would be clozapine. Near zero rates of EPS. Other rare side effects, we talked about NMS, seizures, talked about blood dyscrasias, the thermoregulation, the black box warning. So you're good with that. Hyperglycemia, that's related more to the metabolic syndrome. So we'll talk about that in a bit here.